Welcome to Impact OC, the only program showcasing the people and organizations shaping Orange County. With your host, Don Camber.
Hello, live from the OC Talk radio studios at UCI's Beal Applied Innovation Center. I'm OC Talk Radio Public Affairs Director Don Camber with another great guest impacting our community in a positive way. The Leonard Cancer Institute at Providence Mission Hospital is proud to have an array of innovative treatment options, including surgical robotic systems. Today, I welcome one of Providence Mission Hospital's most talented robotic surgeons and Leonard Cancer Institute's Director for Lung Cancer, Dr. Samir Kannan. Thank you, Dr. Kannan, for being on Impact OC.
Oh, thank you, Don, for having me. It's a pleasure.
Dr. Kannan, please tell us how robotic surgery is transforming the lives of your patients.
Well, I think robotic surgery is a tremendous new advancement. Want to point out that robotic surgery is it's robotic assisted. The surgeon is still doing the surgery, but the tools are now the technology and the allows the surgeons to do an operation with finer precision, safety. Originally, the robotic system was originally kind of a military concept. The idea was the military was going to have these machines by the front and have the surgeons kind of back behind and safe. It never really went anywhere and kind of sat, so to speak, dormant. And so the private sector took it up and they took these machines and they advanced them. And so I've had the pleasure of working with them since 2008. But the idea is that a surgeon, when the patient's asleep, will insert these instruments, and they're small, minimally invasive, small incisions, maybe 8 millimeters in size. And then they'll bring the robotic system to connect to these instruments. And then the surgeon is in the room. They're just a few feet away. They sit down at the console, and they're able to put their eyes inside the machine and put their fingers, and they can control the instruments with fine precision. So now as a surgeon, you can zoom in 10 times. You can, it's three-dimensional. The older systems that we had that people are familiar with, laparoscopic or thoracoscopic, you'd just be looking up at a screen and it would be two-dimensional. The other thing is that the instruments were kind of fixed, and the robotic mimics your hand movement, so it has kind of full articulation. And so from a surgeon's point of view, when you're operating on someone, the safety of being able to zoom in, three-dimensional, and have the instruments literally mimic your hand movements, your wrist movements, it's truly amazing. And so I found as a lung cancer surgeon, I can do a better, safer, more precise cancer operation on my patients and get the cancer out and sample their lymph nodes. And then, of course, when you're done with the operation, you kind of disconnect or undock the instruments and remove them. And when you close the incisions, now the patient has very small incisions, so their recovery is faster, their pain is less. The average length of stay for many of my patients with lung cancer surgery is 1 or 2 nights. The old-fashioned open incision we used to make, they'd be in the hospital 7 or 10 days. Now I try to get them home after day 1 or day 2. They're able to go back to work and go back to their families, fly, exercise. So it's not just they have a better cancer operation, they have a better recovery, and their quality of life afterwards is much better. It originally started, the robotic surgery, they started doing hysterectomies first, and then prostatectomies, and that was kind of initially how they started, but now you can do it for lung, thoracic or lung chest cases. You can do it for colon cancer. A lot of the general surgeons are doing other, hernia repairs. So it's really expanded its specialties in terms of how they're taking care of patients. It's really amazing.
In some cases, is this better than what traditional medicine was?
Oh, yes. Yes. I think that I used to kind of joke with my patients when I used to do surgery open, it was easy on me and hard on them. And now it's the other way around. It's harder on the surgeon in the sense you have to train and do it really well, but it's so much better for the patient. And so, again, the recovery, there's really the precision. You can imagine if I'm dissecting a blood vessel or a lymph node around a blood vessel, and I was doing it open, or I'd have to use special eyeglasses to zoom in. Now with the robot, I can just zoom in with the camera and with very fine instrumentation, dissect all those lymph nodes off the blood vessels. I can see them three-dimensionally. I can manipulate with really fine instruments. So the precision and the safety is truly amazing. And so I think it's just tremendous benefit for patients. Again, they get a better cancer operation and they have less pain and they get recovered faster.
Now, do you do it for diagnostic purposes as well as treatment?
Sure, yes. You can use the robotic approach to diagnose. Most of us will use it more on the treatment side because if you're going to make multiple incisions and invest some time for the patient and the recovery, it's I guess time better spent for curative purposes in terms of treating a cancer, but you can absolutely use it for diagnostic purposes. I think one of the really fine, amazing things is that the robot again is a tool, just like any other tool that we use, and so there's a lot of applications. You can imagine that. One of the thoughts the companies had is imagine you have a small town in Alaska and there's a surgeon, maybe they'll be able to put the instruments in and set it up so a world-class, surgeon hundreds of miles away could then perform the operation and the local surgeon can kind of be there assisting. So the idea with the future and the technology of some of these ideas is that, how can we deliver care sometimes to people that before we weren't able to. So I think there's potential for some of this technology to really be in the hands and to reach, people who otherwise would have to travel thousands of miles. Now maybe the technology can come to them and the skill sets can come to, the patient, so to speak. So I see that as a potential future.
Well, is it worldwide?
Yeah, the predominant Da Vinci is in the United States, but they are worldwide. I think I might misspeak, but I think Japan and then Europe are the other major markets that employ the Da Vinci or the robotic system.
Tell us, when you tell a patient that you have the opportunity to have robotic surgery, do they have an option to say no?
Of course they do. A patient always has an option to say no. I think that what I tell my patients, and I firmly believe it, is that I've done open, I've done video assisted or thoracoscopic, and now I choose to do robotic because I know it's better for them. Again, it's just a better, safer cancer operation. The traditional scope is a uniocular scope. So when you see it on the screen, it's just one eye. The robotic technology is fascinating. The scope itself actually has two channels so that the two different cables are housed inside the system. So when it comes to the console that the surgeon sits at and they put their eyes in there, there's a left eye and a right eye. And, you could just imagine if your surgeon now has, 3D, two eyes to do your surgery versus kind of a one eye screen. I just tell patients, just imagine the difference in the terms of your cancer operation, the safety. Why wouldn't you want to have something like that? The instruments, instead of just kind of being fixed, they can fully articulate. I can sew, I can zoom in, I can grab lymph nodes. Again, why wouldn't you want your surgeon to have the best tool available to do your cancer operation? And almost every patient I've had is excited, and they kind of want to not fall asleep too fast because they want to see the robot when they roll in the room. And there is the capability with the Da Vinci systems where in a confidential way I can record their videos, and if the patient wants it, I can send it to them. So we have that capability as well at our hospital. So I'm very excited that it's called the Orpheus system. But again, it's connected so that you can capture the either still shots or short video clips that I can share with the patient if they wanted. And then you can also use that same technology if you want to teach other surgeons or teach residents if you have a teaching program like at the university, for example. So I think in a nutshell, the technology has entered the medical field to give patients precision medicine. The robot's not doing the surgery. It's a tool that the surgeon is using to help do a better, safer, more precise operation, allow them to recover. It's really fascinating. And here's an example. When you're looking at the screen, let's say I'm not sure there's a blood vessel there. There's a mode in the robot, we call it Firefly, where you can change, and the color of the screen is kind of like a green screen, but you see the blood vessel. Like you can see where it is, and then you can switch back to your regular mode. The safety of then saying, oh, well, that structure there has got a blood vessel in it, and I'll kind of avoid that so I don't injure the patient or have it bleeding. There's just so many layers that are built into the robot for safety and for training for residents. You can kind of do simulations, on the robot before, if you want to kind of sit in the computer and do practice operations in a simulator. That way, when residents are trained before they go out and actually do things on their own, they can be, spend hours in training. It's kind of like when you have pilots, right? They'll simulate, flying a plane hundreds of hours before they'll actually do it. So the same thing can be done for surgeons. So it's really an amazing technology. It's an amazing time period.
So when you're trying to get the cancer, are you able to get it better with robotic assistance as opposed to the other ways?
I think that I can speak, let's say, for lung cancer. You can get it out with an open or a thoracoscopic approach. I think that the precision of the robot allows you to dissect the tissue, causing less trauma, so that the patient heals faster. They have less pain. But it's more when I sample the lymph nodes. Studies have shown that surgeons that do robotic surgery were able to sample more lymph nodes and more complete lymph nodes to better stage the patient and potentially cure them if we take out all, the tumor that we could possibly see. So I think for the fine dissections in terms of less bleeding, less, we call it air leak. So if the tissue is not leaking because it's not damaged, trauma to the tissue in terms of swelling or pain after surgery, all of that is improved. I was able to, kind of look back and see some of my results, and by doing it robotically, instead of having people be in the hospital 3 or 4 days with the scope, with the robotic assisted, 2 or 3 days now, or sometimes even just 2 days. The cost of the hospitalization then go down, less complications for the patients in terms of societal costs. Also, they're back to work faster. There's, less workers' comp, less disability, less time off work. And so I think the investment in this technology from a society point of view is tremendous benefit to our patients and to our population.
Where are we with the mortality rate of lung cancer?
Mortality for lung cancer, unfortunately, lung cancer is the #1 killer. It will kill more Americans per year than colon or prostate or breast cancer combined. I think the latest numbers are between 150, 160,000 Americans every year will die from lung cancer. Of course, we hope with no smoking and education, and then of course things like lung cancer screening, that we can reduce those. And then of course with lung cancer screening, my My hope then is that we catch it with a stage 1 or early stage lung cancer, and we can do robotic surgery to cure those patients.
How do you screen for lung cancer?
It's a low dose or non-contrast CAT scan. That's the latest recommendations. This has been a few years. We used to screen with chest X-rays. That wasn't any good. The old recommendation came out if you were over the age of 55 and you had smoked 30 pack years, which means a pack a day for 30 years. But this January, we changed the guidelines. Now, if you're over the age of 50 and you smoked only 20 pack years or a pack a day for 20 years, you should go get a low-dose screening CAT scan. And the hope then is if they detect a nodule or a spot on your lung, that perhaps either a biopsy or a surgery, and it turns out to be a lung cancer, we could cure you.
What percentage of people with lung cancer have smoked?
90+% of lung cancer are smokers or former smokers. So there are a small percentage of non-smokers, and those typically can be just genetics. Some people have genetics, air pollution, or there are certain environmental or work exposures. But 90+% are from cigarette smoking. We don't know enough about the long-term impact of what vaping will have, but we do know that cigarette smoking is definitely the primary reason why we have smoking, not just in this country, but worldwide. They talked about in the 19th century, the 1900s, that we would have 100 million people die from smoking, and the expectation is in the 2000 century that we could have 1 billion people die from lung cancer, and smoking-related diseases. So it's really just it's preventable. If we can just educate our young, healthy men and women out there not to smoke, and if you are a smoker, there's lots of resources to help you quit. That's the number one thing that we'd encourage people to do to live long, happy lives. Also,
there's the secondhand smoke to be worried about.
Yeah, secondhand smoke is a risk factor. It's not as powerful as the first, but when you look at secondhand smoke, I forget the exact number, but there are anywhere from 50 to 70, carcinogens or known chemicals in the secondhand smoke that can cause cancer. Things like arsenic and formaldehyde. All of these things are byproducts of the smoke. So if you're in a room or a car or a contained area with someone who's smoking, you're basically breathing in all those secondhand byproducts. So you in essence are smoking too. Thankfully we live in a state where we have some very protective laws, but not all the United States has those. I think the highest number of smoking and secondhand smoke exposures are in the southeast of the country, where they don't have as many laws about not smoking in public places and restaurants like we do here in California. But I've seen many patients over the years whose spouse or parent was a smoker, and that's how they got their lung cancer. And hopefully we can spare them that in the future with more education.
So when a person is told they have lung cancer and they can have robotic surgery, do you go through a whole explanation of how the surgery will occur before they go on the table?
Absolutely. And I explained to them, everything that's going to happen beforehand, how the surgery is going to be done, all the risks. But I also, tell them, hey, I have a website. They can look at videos I've put up there. If they want to actually see the actual whole robotic surgery done, they can go for that too.
Dr. Kanan, how do you want to be perceived?
I want to be perceived as a very passionate, but also compassionate, cutting-edge robotic surgeon who is doing his best to make a difference in the impact of lung cancer in the community.
Thank you, Dr. Samir Kanan, for being on Impact OC. He's the director for lung cancer at the Leonard Cancer Institute at Providence Mission Hospital. And I thank everyone for tuning in. I'm OC Talk Radio Public Affairs Director Dawn Camber. Have an impactful day.
You've been listening to Impact OC, the only program showcasing the people and organizations shaping our community. Right here on Orange County's only community radio station, OC Talk Radio.